This webinar is being put together in conjunction with Prostate Cancer UK, the Royal College of Radiologists and the British Society of Urogenital Radiology. Okay, so I'm going to talk about MR imaging in prostate cancer. I'm going to talk about how we currently diagnose prostate cancer and some historical perspectives, why diagnosis is changing, and it's changing very rapidly at the moment. I'm going to talk a little bit about local staging. Obviously, I'm going to dwell quite a long time on multiparametric MRI and how we use this. I'm going to talk about PI-RADS, the scoring system, love it or hate it. It's here at the moment and it's probably here to stay. Things to look out for, some of the pitfalls that we can come across with multiparametric MRI, and then we'll finish with a conclusion to try and wrap it all up. So diagnosis traditionally has been made with a clinical examination, i.e. digital rectal examination, made by the urologist. And we know this is a very insensitive and non-specific test. You can measure the PSA, prostate-specific antigen. It's called specific, but unfortunately it's not specific to prostate cancer. The PSA can be elevated in prostatitis and various other conditions. And indeed, some prostate cancers may not even have an elevated PSA. Transrectal ultrasound and biopsy can give cancer grade and the approximate size of the tumour. And this is what's been done for an awful long time to try and diagnose prostate cancer. MRI traditionally has then been used to stage the cancer rather than to make the actual diagnosis. Just to go through a quick image from a truss scan. This is a sort of axial or transverse image. There's an area of low reflectivity here in the centre, which is a cyst, and this bit's labelled tumour. There's tumour in there somewhere, might be out here, we don't really know. And on the longitudinal scan, you can see this dotted line where the biopsy needle will go through the peripheral zone, hopefully even into the transitional zone, and take biopsies of the gland. Now the problem with this is PSA, as I've already alluded to, and biopsy, these are very unreliable tests. Biopsy location is fairly random. You could do a biopsy one day on a patient and get prostate cancer, Gleason 8, Gleason 9, come back the following week, take another biopsy and find what you think is an insignificant Gleason 6 tumour. So biopsy's got a low sensitivity for clinically significant disease. Biopsy is not very repeatable, as I've already said. Now let's give an example, a purely hypothetical example. This is a patient who we think's got hepatocellular carcinoma. Let's pretend we don't have a good way of imaging the liver at the moment, which thankfully is not true. Patient's got a raised AFP. We think they've got an HCC somewhere, so the only way to find this out is to do biopsies. We take 3 biopsies from the left lobe of the liver, we take 4 from the right, and one of these biopsies picks up a tiny area of tumour. So we say to the patient, yeah, there's a tiny area of tumour, very easy to treat, you're going to be fine. But what we've actually missed is this large area more centrally of very significant tumour. And this is exactly what happens in the prostate gland when you don't do MRI prior to your biopsies. You don't know where the significant tumour is. So an ideal test would be sensitive, non-invasive, and it would find significant disease. That would be anything greater than Gleason 3+3 and more than about 0.5 centimetre cubed in size. This ideal test would give the location of the tumour and the volume of the disease. It would hopefully give an estimate of the grading of the disease, although that would be predominantly on biopsy. But of course we would like accurate staging, including staging of the lymph nodes. That's very important. So standard prostate MRI, as it's been done traditionally with T1 and T2 weighted scans, is pretty good. It's high resolution. It's not bad in the peripheral zone and the transitional zone. It misses small tumours, but it is actually quite good for staging. So for local staging, it's not a bad test. We'll just go through some examples. This is a T1 weighted scan. This patient's already had a biopsy, and that gives these areas of artifact which are high signal on T1. When you go to the same slice on T2, you can see these appear low signal. Tumour also appears as low signal. So this can actually be quite confusing and could lead to a false positive if you don't realise on a T1 weighted scan that this is actually due to post-biopsy hemorrhage. So we stage the tumour on the MRI. If we see a small focal tumour, more centrally, this could be T1, slightly larger tumour, could be T2. Or if we see the tumour extending outside the gland through the so-called capsule, but of course the prostate gland does not have a histological capsule, this is just an area of compressed tissue, this will be T3 or T3A. If the tumour goes into the seminal vesicles, I don't have that on this scan, that will be T3B, and if it goes even further outside the gland to invade adjacent structures such as the bladder, the rectum or the pelvic sidewall, this will be T4. So standard MRI, as we currently do this, is actually pretty good at making this sort of staging. Here's a fairly gross example, area of low signal on the right of the gland. In fact, most of the gland's abnormal, and the tumour is extending all the way across along the perirectal fascia to the posterior pelvic sidewall. So this would be a T4 tumour. On the coronal scan, you can see it extending superiorly along that fascia as well. Here are the seminal vesicles seen on the coronal scan. These are slightly collapsed, which makes them a little bit lower in signal, but in fact they don't appear to be invaded. Here's another example. This patient has got a very definite bulge on the left-hand side, homogeneous low signal. This is all very likely to be tumour. This bulge is one of the features we look for to say that this is T3 disease. The other thing we can look for is the length of the so-called capsule or margin of the gland that's involved with tumour. And if it's more than 2 or 3 centimetres, we would say that this is a soft sign of T3A tumour. It's likely that the tumour could have gone out into the periprostatic fat. Unfortunately for this patient, on a slightly higher axial slice, you can see the left seminal vesicle here is uniform low signal, and this has been invaded by tumour. Something to watch out for here, if you look on the right-hand side, this low signal structure here, this is actually the vas, and this is fairly fibrous tissue and looks quite low signal on the T2 weighted scan. Now, the other thing to note is you would always look at the T1 weighted scan on these patients and check that this isn't low signal due to hemorrhage. So if that was hemorrhage, it would look bright on a T1 weighted scan. In fact, in this patient, this is tumour into the left seminal vesicle, so this is T3B disease. This patient, it's a pretty awful scan. The problem here was the patient was in considerable discomfort and couldn't lie still. This is a sagittal T2 weighted scan, and you can see the tumours extended all the way posteriorly and superiorly involving the bladder wall. It's gone through the rectal wall all the way down here, and this is a nasty T4 tumour. Just going through some axial slices on this patient here, you can see the features of BPH. You get this sort of confusing, chaotic appearance in the centre of the gland. This is the transitional zone, which is expanded. You get areas of high signal on T2, which are more glandular areas of BPH, and the lower areas, lower signal areas, are stromal BPH, which makes up less of the tissue in BPH. But more anteriorly here, we've got this area of homogeneous low signal. This involves the anterior peripheral zone on both sides and goes out into, well, what could be the fibromuscular stroma, but I think this is most likely to be tumour. But the problem this patient had was they'd already had transrectal ultrasound and biopsies, and the biopsies were all negative. There was no evidence of prostate cancer. But because the PSA was persistently raised, the patient went on to have an MRI, and I think that's very suspicious for an area of tumour anteriorly. Now you can see if you do transrectal ultrasound and biopsies along this sort of pathway, unless you put your needle very far in, which some of them aren't long enough, you would never biopsy this anterior tumour, and this would be completely missed using traditional techniques. I'll just show you another example. This patient's had TURP. You can see the TUR cavity here, but anteriorly here is an area of low signal. And again, this patient's biopsies have come back negative, as had this patient here, this area of low signal anteriorly, involving predominantly the transitional zone. Again, I think that's suspicious for tumour. So what's the answer to this? How do we get around these sorts of problems? How do we deal with this? Well, NICE looked at this with Clinical Guidance 175 in January 2014. And they looked at the literature, which has actually gone back quite a few years now, looking at multiparametric MRI. Now, what NICE consider to be multiparametric MRI is the combination of a T2 weighted scan with another technique, such as diffusion weighted imaging or dynamic contrast enhancement. So they wanted 2 of those 3 types of scan to call it multiparametric. Now, most of the literature you'll see, and what we call these days multiparametric MRI, is involving all 3 of those techniques, although there is some debate as to how useful dynamic contrast enhancement is, and we'll go on and talk about this in a few moments. So what is diffusion-weighted imaging? Well, this is a type of echoplanar imaging using very rapid MR gradients, and I would say pretty much most scanners in the country now are perfectly capable of doing pretty reasonable diffusion-weighted imaging. It assesses the diffusion of water molecules in different tissues. Now, this diffusion of water molecules is restricted. It's held up in tightly packed cancer cells, but also in any other tissues where the cells are tightly packed together. So it's not specific for cancer. Now, what we use are 3 different B values. That's 3 different magnetic field strength values, gradients. And from this, you can calculate what's called an ADC image. That's an average diffusion coefficient, and it looks at the diffusion of the water molecules at these 3 different gradient strengths, and then comes up with this average image, which is called the ADC Map or ADC image. It's actually very useful, as you'll see in a moment. So the figures we use a B200, we use a B400, and we use a B1400 gradient. And the B1400 is actually, in my opinion, and most people's opinion, I think, the most useful value to look at. The only problem is, as you go through higher gradients from 200 up to 1400, your signal-to-noise ratio diminishes and your image gets poorer quality. Now, you can get around this by using a bigger field of view, which we've used here, a smaller matrix, or slightly thicker slices, but ideally, you want your slices to line up with your axial T2 weighted slices so you can directly compare the 2 side by side. Now, some scanners will go out beyond B1400, particularly if you're lucky enough to have a 3T scanner, and then you can go out to B2000 or even further. Now, what some manufacturers will do is they will calculate this high B value. So they won't actually go out to B1400, but they'll use a calculated value, which can actually give you some very nice images. This is the patient I showed you earlier who had negative biopsy. There's the area of low signal anteriorly on the T2. And this is the ADC map, and you can see that really is quite low signal. And this is certainly consistent with tumour. And that was biopsied transperineally, and that came back as tumour. This other patient, again, low signal anteriorly, slightly higher signal on the B1400, not as high as I'd like to see for a higher grade tumour, below on the ADC map, and this came back as Gleason 7, 4+3. And this other patient I showed you, there's the anterior tumour, there it is on the B1400, there it is on the ADC map, and this again came back as Gleason 7, 4+3. So using this technique, we can give an idea of the location of the tumour and indeed the volume of the tumour. You could look at this in different planes and you could measure true volumes if you really wanted to. Here we have a tumour anteriorly on the left. There it is, high signal on the B1400, and it shows definite restricted diffusion because it's low signal on the ADC map. If you only look at the B1400, you can get caught out because you can get what's called T2 shine through. Areas which are high signal on a T2 weighted scan can look very high even out to B1400. So it's important you do look at the ADC map as well. Now, this is a patient who had a raised PSA, negative biopsies. They came for an MRI scan, which you could argue they should have had done beforehand. And there's an area of restricted diffusion over here on the B1400. It's a little bit bright, and it's low on the ADC map. Now, you can get that appearance in thickening of the surgical capsule, but we were suspicious that this was tumour because it was really quite bright on the B1400. The patient had a biopsy, and again, that came back as Gleason 7. You can fuse these images together, which can make interpretation a little bit easier, particularly if you're trying to align the images up side by side, which is the way you need to look at these. So I'll just show you an example here. There's a small probable tumour in the left posterior peripheral zone on the T2 weighted scan. There it is on the B1400, very bright. Now, this central image, what we've done is superimposed this B1400 onto the T2 weighted scan to give you this fused image. And this is actually quite useful and a very useful way to correlate the two images unless you put them side by side. So can we give a grade of disease? Can we estimate the grade from diffusion weighted imaging? Well, there are several papers that show you can. These go back to 2007, both of these from 2010, and these show that high-grade tumours have got a low ADC value. You look at this tumour on the T2 weighted scan and you look at it and you think, well, actually, it really does look like quite a nasty high-volume tumour. It's very bright on the B1400 and it's significantly restricted on the ADC map. This came back as a Gleason 9 tumour on biopsy. Here's another example. Quite a large area of low signal, a bit high on the B1400, some restriction posteriorly here. The area of highest restriction is here on a lower slice, and this area came back as a higher Gleason score on biopsy than this area over here, so that does correlate quite well. This is another paper from 2012 which quite clearly shows that the grading of disease correlates with the ADC value. So if you look in the column here on the left, Gleason 3+3, the ADC is 1.1, Gleason 3+4, 0.97, and Gleason 4+3, 0.8. And that was a significant difference. So the higher the Gleason score, the lower the ADC value. So basically, the higher Gleason score tumours look blacker on the ADC map. And this is just shown in a different chart here. But you can see there is quite an overlap between Gleason 3+4 and Gleason 4+3 compared with Gleason 3+3. So the Gleason 3+3 are probably certainly the less significant cancers. So we don't need to worry too much about those unless they're high volume. But these tumours here do certainly have a lower ADC value. So the ADC value and the B1400, the diffusion weighted imaging, this reflects the average amount of fluid, i.e. the glandular fraction of what you're looking at. And that correlates with the Gleason score. But the Gleason score is not only influenced by the cellularity and the tissue density, it's influenced by cell size and shape, the size of the glandular spaces, and indeed the presence of other components. Now, we can't tell those things on MRI, so we're certainly not going to be able to replace the histologist with our wonderful ADC maps, but we can give some indication of the grade of tumour. I'll show you another example here. This patient, who's only 50 years old, has got an area of tumour here on the T2 weighted scan going into the base of that right seminal vesicle. So that looks like T3B disease. There it is on the B1400. There it is on the ADC map. And this is actually very dark, very black. And if we look at some lower slices, the whole left side of the gland, in fact most of the gland looks abnormal, but the restricted diffusion and the high signal on B1400 is confined predominantly posteriorly into the right. There it is on the ADC map. If we come a little bit lower, there's this big nodule here, another nodule there. I call them nodules, it's not BPH, this is actually tumour, and there's significantly restricted diffusion around its margin. And again, on the ADC map, it's very low signal, slightly higher in the middle. So the bit in the middle may well be less active tumour, it could be more fluid here, but the bit at the outside certainly is high grade tumour, and this was biopsied and came back as Gleason 9. Now you can see on this coronal image quite nicely that this tumour is bulging out definitely from the gland. It's involving the muscles here, the levator muscles, and this is a T4 tumour. Very nasty tumour in a young patient, very aggressive. What about dynamic contrast enhanced MRI? Does it have a role? Well, a lot of people argue that it does have a role now, and it can sway you one way or the other and affect the scoring you're going to give a certain lesion. And what we're looking for with contrast is early tumour enhancement. It's pretty much as simple as that. Prostate cancer shows early and more prominent enhancement than the surrounding tissues normally. We know that more aggressive tumours are more angiogenic. The tumour vessels are abnormal. There'll be a higher vessel microdensity, and these abnormal vessels leak contrast, so that shows you enhancement. So the way we do this is we give IV gadolinium, we do a rapid T1 weighted gradient echo sequence, and we keep repeating that sequence over several minutes, possibly out to about 2 minutes or even longer. Now there was a vogue for measuring all the way out to about 4 or 5 minutes and measuring the washout, but I think the evidence for that is certainly far from clear. This paper here, which I'd recommend you read, gives a very good overview of dynamic contrast enhanced MRI in prostate cancer diagnosis and management. That was AJR 2012. There's a very nice graph here which shows what happens with a tumour. The red line is the tumour, and there's peak enhancement. The blue line is normal prostate tissue, which has got much slower enhancement. When you measure it out at about 4 minutes, the prostate cancer may well have washed out a bit, but that doesn't always happen. So the thing to look for is this peak enhancement, which you can see may happen even earlier than 30 seconds. So you need to image quite early. It's again shown quite nicely on this graph. This is an area of normal tissue, normal peripheral zone. There's the contrast wash-in, and there's an area of potential tumour, and there's the contrast wash-in. So you can see that wash-in there was at about 9 seconds to the peak, whereas the peak here in normal tissue was about 35 seconds. And what they've done is they've done a colour map to show exactly where the rapid wash-in of contrast is, and that's the red bit, which interestingly corresponds to the arterial flow as well in the femoral artery seen there. And on the block section for the prostate gland, that's the area of the tumour. So really quite a beautiful correlation between enhancement and tumour. So we do rapidly acquired T1 weighted gradient echo scans. It's important you do the pre-contrast scan to compare with the post-contrast, and indeed you can subtract one from the other. Now this becomes useful when you've got an area of hemorrhage, which can be high signal on the T1 weighted scan. And if you then get enhancement in there and you subtract it, you'll be able to pick that up. But it's actually very difficult if you don't subtract. What we use, because we use Siemens scanners, is we use a vibe sequence on GE. I think it's called a lava sequence. And all the manufacturers have got their own proprietary rapid gradient echo sequences. And I say rapid because you need to be able to image the whole prostate gland in less than 10 seconds time resolution. And we carry this scan out for about 2 minutes. So we get multiple images over about 2 minutes, which sounds like a lot of images to look at, but actually you can scroll through these incredibly quickly to see areas of early enhancement. So what we're looking for is focal, earlier or contemporaneous enhancement with normal adjacent prostatic tissues, predominantly earlier enhancement. Here's an example, area of low signal in the right peripheral zone. Here it is on the B1400. Here it is on the ADC map. You see there's something a little bit more subtle on the left as well. But the early enhancement is really quite noticeable on this vibe sequence. And then you can see it washes out on the later phases fairly rapidly. So this now brings us on to PI-RADS. This is the prostate imaging reporting and data system. We're now on version 2, which came out in 2015. Version 3 is underway. Where did this come from? Well, this came from back in 2012, when the European Society of Uroradiology developed guidelines for reporting prostate MRI and performing prostate MRI. And they came up with this scoring system called PIRADS. Now, I'm not a great fan of scoring systems, but it does have some useful features, and it's certainly very good as a learning tool and telling you what you need to be looking for when you're looking at prostate MRI, multiparametric MRI, and I do recommend that you read this. It's freely available online. Global standardization and variation in the acquisition, interpretation and reporting of prostate multiparametric MRI examinations, and it's intended to be a living document that will evolve as clinical experience and scientific data accrue. And indeed, it is living. We're now on PI-RADS 2, and PI-RADS 3, as I said, is already being developed. So this is constantly changing, which is the best sort of document you have, and it just shows how our experience is changing with the multiparametric MRI from year to year. One of the things they looked at first of all is the timing of biopsy. Clearly, post-MRI is the optimum. Patients should be getting their MRI scans prior to any biopsy. Otherwise, you get a post-biopsy hemorrhage. And how do you know which bit to biopsy? We're back to doing random prostate biopsies again. Patients should be prepared. Ideally, they should have an empty rectum. They're given an antispasmodic. We usually give buscopan. If there are contraindications, we give the patients glucagon, and that minimises any motion artefact, which can certainly affect some of the sequences quite significantly. 3T or 1.5T? Well, if you've got a 3T scanner, great, because the advantages certainly outweigh the disadvantages. You can get higher resolution images, and you get a higher signal-to-noise ratio. We don't currently use endorectal coil, certainly not in our centre, and I don't know of very many places in the UK who do. It's certainly a lot less comfortable for the patient, and patients are going to be a lot less compliant with this, particularly if you're proposing MRI as part of an ongoing surveillance program. The endorectal coil will, however, give you a higher signal-to-noise ratio and resolution. Now, the PI-RADS team came up with a sector map as well, and they said the use of the sector map will enable radiologists, urologists, pathologists and others to localise the findings described in the MR reports. And it'll be a valuable visual aid for discussions with patients about biopsy and treatment options. I personally don't use this map. I'll just show you an example of it here. What I tend to do is give the slice number with the abnormality, its size and its location, which our urologists can directly look at on PACS, and they can import that slice into image fusion software to allow targeted, more accurate targeted biopsies. And indeed, with the PACS system, which we're shortly to get, so I'm told, I'll be able to draw around a lesion, and again, that can be directly imported into their biopsy software. But if you just look at this diagram for a moment, you can see anteriorly here at the base, you've got the anterior fibromuscular stroma, which is marked in blue. This can be quite low signal on T2 weighted scan. Then we've got the transitional zone, then we've got the central zone more posteriorly, which of course will be compressed by growth in the transitional zone, and then the peripheral zone around the edges. We've got that at several levels. We've got the base, mid-gland and apex. We've got the coronal image, so you can draw on here some of the vesical invasion, and we've got a sagittal section here to show exactly where it is in the sagittal plane as well. And then at the bottom we've got the urethra, and the top we've got the seminal vesicles. You can use that if you like. It all depends on your working relationships with your local urologist. So how do we do the PI-RADS scoring? Well, PI-RADS scoring very crudely goes from PI-RADS 1, where we don't think there's cancer, to PI-RADS 5, where we say, well, we think this is definitely cancer. And there's a whole spectrum in between. I'll go through how you score these now. What they did say in the PI-RADS document, they said it is anticipated that as evidence continues to accrue in the field of mpMRI and MRI-targeted biopsies and interventions, specific recommendations and algorithms regarding biopsy and management will be included in future versions of PI-RADS. The other interesting thing they said, which I would entirely agree with, is when T2 weighted imaging and diffusion weighted imaging are of diagnostic quality, dynamic contrast enhancement plays a minor role in determining PI-RADS assessment category. Doesn't mean it's not worth doing, but it's less important than the other two imaging techniques. And where this comes into play is if diffusion weighted imaging gives you a PI-RADS 3 lesion, i.e. intermediate, you're not sure, positive contrast and early contrast enhancement in the peripheral zone could upgrade this to a PI-RADS 4 and could sway you between biopsying that lesion or not biopsying that lesion or biopsying a different lesion. So contrast is worth giving. So how do you score this? Let's first of all look at the peripheral zone. Here's the PI-RADS score down this side of the table. Here's the score from diffusion weighted imaging down here. And the two middle columns here are the T2 weighted scan and dynamic contrast enhancement. Now, as you see here in the peripheral zone, diffusion weighted imaging is what's going to affect your PI-RADS score. That goes from 1 to 5, as does the PI-RADS score. But the T2 or dynamic contrast enhancement really could be anything. What you're going to be looking at predominantly is diffusion weighted imaging. But note the DCE here, if it's positive, could shift that PI-RADS 3 to a PI-RADS 4, as I said before. Now if we look at the transitional zone, things are completely reversed. T2 weighted imaging is the predominant sequence. From 1 to 5, PI-RADS 1 to 5, whereas diffusion weighted imaging could be anything and contrast enhancement could be anything. But diffusion weighted imaging could sway this between 3 and a PI-RADS 4. Now if we look at T2 in the peripheral zone, the PI-RADS score. I'll go through how you actually go about getting this score. PI-RADS 1, normal tissue. PI-RADS 2, linear or wedge-shaped hyperintensity. Not too worried about that. PI-RADS 3, heterogeneous signal intensity or non-circumscribed rounded moderate hyperintensity, so slightly low signal. PI-RADS 4, this is where it gets more interesting. These are circumscribed, homogeneous, moderately low signal masses, less than 1 centimetre in diameter. This looks like tumour in the peripheral zone. PI-RADS 5, this is the same as 4, but it's bigger, greater than 1.5 centimetres, and it may have definite extraprostatic extension or an invasive behaviour. So that will be scored PI-RADS 5. So, look at T2 PI-RADS in the transitional zone. Homogeneous intermediate signal intensity is normal in transitional zone. We get areas of BPH. These are well encapsulated, very well circumscribed. These are normal. That will be given at PI-RADS 2. Heterogeneous signal intensity with slightly ill-defined margins, that's PI-RADS 3. It might be BPH, it might not be BPH. But if you see an area of low signal in the transitional zone on T2, which is lenticular, non-circumscribed, homogeneous, and low signal, it's a PI-RADS 4. This is more worrying for tumour. If it's even bigger, it's even more worrying. What you tend to measure is the greatest dimension, be it in the coronal plane or the axial plane. How does diffusion weighted imaging come into this? Well, this affects the scores as I showed you on the previous slides, but really what you're looking for is hyperintensity on the B1400 and low signal on the diffusion weighted imaging in the peripheral zone or the transitional zone, but we know that this is more reliable in the peripheral zone. So a PI-RADS 4 will be a focal, markedly hyperintense on the ADC, markedly hyperintense on the high B value scan, less than 1.5 centimetres in dimension. If you saw the same thing, but it was more than 1.5 centimetres, it would be more likely to be a PI-RADS 5. Excuse me whilst I just take a drink of water. Now, where does dynamic contrast enhancement come into this? Well, as I said before, if you've got a PI-RADS 3 in the peripheral zone and you see focal or early enhancement than the normal tissue, that's more likely to sway you and upgrade it. It's a little bit more confusing than transitional zone, but certainly in the peripheral zone, it's more useful. So how do I report prostate MRI? Well, I take a fairly pragmatic view to this. I think, what does the surgeon or the oncologist need to know about this patient? What they want to know is how large is the gland? Is the PSA very elevated just because they've got lots of BPH? Is there significant cancer present? If there is, where are the tumours? Which bit do they go and biopsy? What needs treatment? I'd like to give an assessment of how aggressive I think it is. I want to be able to stage the tumour. I want to be able to show any evidence of metastases. So I'll give you an example. Here's a patient with BPH. They've got a large gland. They've got the transitional zone grossly expanded here. The peripheral zone is fairly well compressed. So I give the dimensions in those two dimensions. And then on a sagittal scan, I get the craniocaudal dimension. You multiply the three together, times it by 0.52, and that gives you an approximate volume based on an elliptical formula. I'm sure some of the more modern PACS systems will be able to give you a more accurate figure than that. So here's another example. So I've got the volume. Here's a tumour. Showed you this before. Left anterior transitional zone and peripheral zone. And I've already looked at the T1 weighted scan. I know this isn't hemorrhage. I've gone through the large field of view T1 weighted scan, looking for lymphadenopathy and bony metastases. I'm now concentrating on the tumour itself. Those findings are all negative. So I'll say the prostate volume is approximately 75 mils. There's an approximately 26 millimetre diameter low signal area with significantly restricted diffusion in the left anterior peripheral zone / transitional zone, mid-gland, highly likely to represent tumour. And then I give the slice numbers. I give the slice number on the ADC or the B1400 and the correlating slice on the T2 scan. And this is what they can use to go and target a biopsy. And staging, I say it appears organ confined. Seminal vesicles are normal. I've already looked at those on other slices. I haven't found any significant pelvic lymphadenopathy or bony metastases. So, in summary, what have we got? We've got a significant left anterior tumour which could be targeted for biopsy. That's pretty much what our urologists want to know from me. Now, whether you convey that image, whether you convey that information by drawing that on an image and putting a PI-RADS score, here I've given a score of 5 out of 5, or whether you just describe it, I don't think it really matters. I think it all depends on your relationship with your colleagues and how they want the reports. So what are the things to look out for? Where can we go wrong? Well, we can go wrong in an awful lot of places. And this is a great paper I came across recently in AJR 2014. Radiologists be aware, 10 pitfalls that confound the interpretation of multiparametric prostate MRI. I've got some examples from that paper and some of my own examples that will hopefully help you to avoid these same pitfalls. Now, one of the things that caught us out when we first started doing prostate MRI many years ago is the central zone. Now, as you get BPH and the transitional zone expands, this central zone gets compressed. And if you look here, it says the central zone appears as a symmetric band of tissue between the peripheral and transitional zones at the base of the prostate, extending from below the seminal vesicles to the verumentanum and surrounding the ejaculatory ducts. In addition, the central zone exhibits decreased T2 signal and decreased ADC relative to the peripheral zone. So you can be fooled very easily into thinking this is tumour. Depending on the level of the axial slice, the two lobes of the central zone may exhibit a dumbbell-shaped appearance rather than appear as a single confluent structure. It's also described as a bow tie sort of shape or a teardrop shape. I'll show you what this looks like. Normal peripheral zone on a T2 weighted scan, that's high signal. A little bit of BPH more centrally, so the transitional zone is expanded. Here it is on a T1 weighted scan, fairly homogeneous. When we come up towards the base, here is the central zone, which is being compressed, and coronally, you see it here and here. You could be forgiven for thinking that that might be tumour. And there's a seminal vesicle normal on the right and a little bit normal on the left. On a slightly lower scan, again, this is the normal central zone, not to be confused with tumour. And of course, this does restrict. Here's the peripheral zone, normal peripheral zone and transitional zone, normal on this slice on the ADC map. When we come up towards the base, there's the compressed central zone, slightly higher, but it's low on the ADC map. So that could make you think this is tumour if you didn't recognise this. I'll just show you a slightly different example, going through these axial slices. Here's the compressed central zone. Coming lower down, that is an area of tumour in the peripheral zone. I'll show you that coronally, because it's shown quite nicely on the coronal slices. Some of the vesicles at the back here, and if you watch as we come forward, there is that compressed central zone, which comes all the way down here. And the tumour is this rounded, ill-defined area here, the coronal slice, which I hope I will be able to show you on the next few slices as high B1400 restricted ADC. Now, just whilst I've got this coronal scan up, this is a very good way to look for lymph nodes. This is a very good place to look for internal iliac nodes at the bifurcation, which you'll see here. And this is a scan I pay a lot of attention to when I'm looking for lymphadenopathy. Just moving on down, here is the B1400, and there's the area of very high signal. That's the tumour, compared with the moderately high signal of the compressed central zone. And on the ADC map, you'll see it here. Quite significantly restricted diffusion. Now, you'll notice this scan, this doesn't actually look that good resolution-wise, but I think when you're doing the diffusion-weighted imaging, it's much more important to get the signal and high signal-to-noise ratio than a high-resolution scan, because your resolution is going to come from your T2-weighted scan. That's your high res, and as long as you can correlate the two with equal slices, you ought to be able to locate your tumour quite well. So the resolution is not as important on the ADC and the diffusion weighted imaging. But nevertheless, this is actually an extremely low resolution scan, and normally we would have higher resolution than that. It's not really time to go into the technicalities of exactly what matrices and things we use for this. Now, this is another example from this paper from AJR 2014. This is a surgical capsule. This is a low signal area where the BPH stops and the peripheral zone starts. It's called a surgical capsule because during TURP, this is where they would stop removing tissue when they get out to this capsule. Now here, you've got asymmetrical thickening in this surgical capsule, and that could potentially be thought to be tumour. And that can show restricted diffusion here on the ADC map. This is an example I showed you before. It just shows the surgical capsule quite nicely. Here's the BPH, and there's that low signal area. So what about hemorrhage? Hemorrhage can be a problem, but shouldn't be a problem if you MR your patients pre-biopsy. But it can be differentiated with diffusion-weighted imaging and contrast-enhanced MRI. Hemorrhage doesn't particularly restrict on DWI, and of course there's no reason why areas of hemorrhage should enhance. If you see something that's a focal mass-like lesion with tumour-like characteristics, well, of course, it's likely to be tumour. The other interesting thing is tumour is often spared hemorrhage. So when you've got hemorrhage, the hemorrhage expands through the tissue and then it stops when you get to the tumour. This is called the MRI exclusion sign in this paper. That's quite a useful thing. Show you some hemorrhage. These are biopsies taken bilaterally, and you can see low signal here on T2. Could it be tumour? Possibly, but if you look on the T1 weighted scan, it's high signal. So this is hemorrhage. So it's very important you do always look at the T1 weighted scan to correlate that, or you can be fooled. The other thing to be aware of is this anatomic distortion you get at high B-value images. This is due to various abnormalities in the magnetic field when you're using particularly high B-value images. So you get eddy currents, you get anatomic borders can appear distorted, nodules can be distorted, metal and air can make it a lot worse. Now this is important if you do diffusion-weighted imaging. You've probably noticed this on anyone who's had a hip replacement. If you've had a hip replacement, particularly bilateral, it can make the DWI completely worthless. The images are distorted all over the place. This can be improved with left to right phase encoding or multi-shot or radial phase encoding DWI type techniques. And I have got some experience with this recently with our new scanner. We did do some diffusion-weighted imaging of a patient with a hip replacement, and actually the images were really very, very acceptable. What this can do is, if you look on your T2 weighted slice, you see where you think the tumour is, and you think it's organ confined, then you see on the ADC map that area of low signal appears to extend outside the gland. Just be wary of that, because that might be due to distortion. It probably isn't a T3 tumour. Rely on your T2 more than the ADC to stage the actual disease. BPH. Now this is an area that's really difficult, and it can be very hard to tell areas of BPH from areas of tumour. Now glandular BPH has got a high T2. Stromal BPH, the bits of tissue in between, which can predominate in some areas of BPH, has got a very low T2. And this can be rounded or spherical. Tumour, the way you differentiate tumour is it might be irregular, it could be lenticular or teardrop shaped. It could have more invasive behaviour. You'll see it crossing between the transitional zone into the peripheral zone. So crossing traditional boundaries within the gland, it's more likely to be tumour. The other thing to look for is look on your persistent high signal. Look for persistent high signal on a very high gradient, say a B2000 or greater than the B1400 if you can. And if it's persistently high signal, that is more likely to be BPH than tumour. Here's an example taken from this Pitfalls paper. And you see an area of low signal within the transitional zone, restricted diffusion on the ADC map. And they biopsied this, and it came back negative, and a 6-month later scan showed it was actually decreased in size. And this was actually an area of stromal BPH, confusing for tumour. So what about lymph nodes? It's important that we know about lymph nodes for staging prostate cancer. If a patient's got metastatic nodal disease, it's a much more poor prognosis. Now, the way we look at this is by looking at lymph nodes and we say, are they big? If they're big, I say more than 8 millimeters in short axis diameter in the pelvis, or lots of them. And the more rounded they are, the more worried I am about them. So this is size criteria, but we know this is not good. Our sensitivity is 42%, specificity is 82%. So we're going to be wrong about half the time. That really is not good enough. Now, we did have some years back ultra-small paramagnetic iron oxide particles, or USPOs. These showed excellent promise. We could inject the patient with these, and it was taken up by normal lymph nodes, but not by bits with tumour in. And really, you could even see half a lymph node with tumour and half a lymph node without tumour. It's very, very good. But due to toxicity and safety concerns and various other reasons, which I'm not going to go into, we can't get this at the moment. So can we be more specific with diffusion-weighted imaging? Can this help us show which nodes are involved, which ones aren't? Here's an example. Here's a pararectal node here, possibly due to prostate cancer. Here it is on the B1400. It lights up like a beacon. Fantastic. Must be tumour. There it is, low signal on the ADC map. Unfortunately, I'm sorry to say, it doesn't necessarily mean this is tumour. In large nodes, normal lymph nodes can look bright on the B1400. Particularly reactive nodes can look bright and restrict on the ADC. It doesn't mean there's definitely tumour. So really at the moment we're still not very good at determining lymph nodes, but what we can do with this is we can say that's where there is a lymph node on that particular slice. That's the bit you can go for when you're doing your radical prostatectomy and lymphadenectomy, if that's what you're needing to do. What about bone metastases? Isotope bone scan. Good if the patient's got lots of bone metastases or they're fairly advanced. Not the most sensitive test. What we tend to do is we do the T1 weighted whole pelvis scan as part of our standard prostate MRI, and that will pick up any areas of low signal suspicious of metastatic disease. We could do diffusion weighted imaging, which we do, and I'll show you an example of that in a moment. And that's actually very sensitive. What about whole body diffusion weighted imaging? This is being done in quite a few centres now. It's a bit of a time hit on the MR scan, but certainly is an extremely good way of picking up disease elsewhere. This patient here on the T1 weighted scan, you can see there's low signal, early bone metastasis in the right inferior pubic bone, so more into the ischial bone. There it is, high signal on the B1400, and it's low on the ADC map. This turned out to be a bone metastasis, and sometimes you can see these high signal on the B1400 well before you'll see changes on the T1 weighted scan. So the diffusion weighted imaging is actually very sensitive. Can we monitor disease with MRI? This is quite a nice paper looking at quite a small number of patients where they looked at the ADC values in patients who were on active monitoring or surveillance. And they showed that when the ADC value reduced, it was associated with progression in these patients. So when the tumour appeared to get darker on the ADC map, now remember you need to look at these with the same parameters and the same windows, otherwise you could be fooled, that's showing that the tumour is progressing. So that's a good way to change your management or to intervene. So, in summary, I hope I've shown you that multiparametric MRI really should be performed prior to biopsy in any patient you think has got prostate cancer. T2 weighted scans are most useful in the transitional zone. The diffusion weighted imaging is useful in both the peripheral zone and the transitional zone, but perhaps more so in the peripheral zone. There are several areas where you could make mistakes and you need to be aware of those. It's better than trust biopsy and PSA measurement, and we know that. It can give you assessment of volume, assessment of the grade of disease, assessment of any metastatic disease, although as I've said, we're not very good with lymph nodes. So who should have a multiparametric MRI? I would have one rather than a biopsy, so any men suspected of prostate cancer prior to the biopsy. Negative MRI, we now know, may obviate the need for biopsy in up to 20 to 30% of patients. Now, some of you will be aware that the PROMISE study has just reported, and indeed some of the results are being presented at BAUS next week. And this will show that using multiparametric MRI, some patients will not need to have a biopsy. So in active surveillance, if they have multiparametric MRI, we can confirm the classification, we can confirm their risk status, and we can monitor tumour progression. In fact, we've got quite a cohort of patients now who are on traditional active surveillance who've had a 6-month MRI scan and they've been taken off that pathway because it's been shown that they've actually got a significant tumour. How do we go about doing this? How do we achieve these aims? Well, we need more radiologists trained in multiparametric MRI. In fact, we need more radiologists nationally. The Royal College of Radiologists assess that we're short of about 1,000 consultant radiologists in this country. Indeed, we have 7 per 100,000 radiologists, 7 per 100,000 patients, whereas in the most of Western Europe, they have between 11 and 12 per 100,000. So we are very short. We need more MRI scanners. We need more capacity to do this sort of work. We need good quality scanning, good quality reports done to a standard. And this, of course, requires funding. And funding, as we know, is fairly short and hard to come by. Thank you very much for your attention.